me to talk about, everybody all good? Okay. Serena asked me to talk about precision education in medicine. Those are my stuff. A couple of disclosures or kind of where I'm coming from. So I work part-time for the AMA. I'm a senior advisor. They pay part of my salary to my institution. And so a lot of the work that I have done has been through the AMA work. And so in part that has been, there's a supplement to academic medicine that came out in February of 24. It is open access. And then a lot of the part of the slides in the work that I'm presenting today is coming directly from my AMA work and from Dr. Desai. Other disclosures are listed as there. And then the very last thing I realized I had to add at the end, I'm not a techie. So do not ask me how you're doing prompts and stuff like that, because that's just not my field. I know a lot, but I do not know much about technology. Okay, so moving on. So the question is, let's see. Our goals are basically to understand a little bit better about precision education and then to talk about some of the current innovations in precision ed. So the question is, like, where does this concept come from? So precision medicine started probably over a decade ago. And I think the audacious goal for precision medicine would be that we would be able to identify each individual and that the medical care that they got would be related to them, their social context, their genome, their preferences, the cancer that they got, is that everything would be personalized to that person. Not sure it actually played out as we hoped, but precision medicine is still kind of developing, as we can say. And so then the question is, why precision education? And so precision education, if you kind of leapfrog off of precision medicine, the goal is that every learner or every health profession gets what they need as they are learning and as they are providing care. And so it really is kind of individualized, customized, personalized to the individual, so that I'm learning what I need to become an emergency medicine physician, and that I am learning what practice changes are happening in emergency medicine. And so it's tailored to my weaknesses, to my strengths, so that ultimately I can become a better physician to provide better care. And so that's kind of the end goal of precision education, is to make it personalized to our learners. So why does it matter? So our current educational system is broken, perhaps, or maybe other people don't think it's broken, but there are pieces of it that's broken. But what we know is that we have this one size fits all process. And so whether or not I'm a emergency medicine nurse who goes back to medical school, or a PhD physiologist who does cancer research, or just a college graduate, when you go into the medical education in the medical school, it's the same thing. Like, everybody gets the same thing. You all still have to take the same biochemistry. You have to take the same physiology. Maybe when you get to your third year, you might get a 2-week elective that you can choose. And then in your fourth year, maybe you may be able to choose. But it really is a one size fits all. And then residency is essentially the same thing. There's a randomness to it. Like, who decides what's your first rotation when you're a medical student? Hopefully you can maybe do some sort of a lottery to get to it. For residency, maybe you can, but it's probably based on your vacation requests and not based on what you need. And so we're pretty much random in the things that we give people. There are also these very disruptive transitions. At the end of medical school in that fourth year, some people use that fourth year effectively, and many people waste it, so that if you see these kind of plateaus or kind of stagnation of learning, it often happens at the transition, is that people stop learning during a period of time. And while some schools have kind of addressed that in terms of 3-year medical schools, so that people graduate in 3 years, and some residencies have done it in terms of promotion in place, the majority are doing a time-based training and not at all related to what they can do or not do. And then the final kind of current system is inequities, is that everybody is learning in a different learning environment with different stresses and different pressures, and we're not actually treating people with equity as they go through. So this is kind of our current educational system. And the result of this is that you end up with these various trajectories. Like these, you may have the student who's really good in their preclinical because they're great at test taking, and then they kind of flounder in their clinical. Or you may have somebody who's a terrible test taker, and then they really excel as they get to clinical. Or you may have somebody who is kind of tracking along, and then all of a sudden have some horrible experience and they just lose their motivation. But what it means is that we just have these variable experiences and these variable journeys that don't get us to an efficient form of education. It's really kind of inefficiencies in education. And it's due to the variable learning environments, inconsistent educational opportunities, the errors and bias in assessment, lack of continuity, fixed mindset, so that you end up with all these different pathways. Ideally, through precision education, we can kind of narrow it down, right? And we can identify when somebody's falling off their graph, or we can kind of push somebody so that they don't lose the transition. And the goal is to really kind of streamline and make it much more efficient as we do our training. And we believe that this is going to be done through kind of really strongly sitting behind competency-based education, being really careful about the transitions, and then paying attention to equity, diversity, and belonging. And so with precision education, we hope that we will increase efficiency, have less disruptions along the way, be more inclusive, and be more reliable with the competencies. So there's an educational saying, is everything. Practice makes perfect, right? And so the practice makes perfect actually comes from Anders Ericsson in the general education field. And he was the one that did the research that said that it takes 10,000 hours to do something, right? 10,000 hours to become an expert in surgery, in chess, in violin playing. But there's a fallacy here, or a caveat with this, is that if you don't get any feedback, you're not going to get any better. And so this lovely video is actually Charles Barkley, who's an expert basketball player and not a great golfer, perhaps. One might think that his swing is not very efficient. If he does this swing 10,000 times, he will not get any better. He has to have feedback. There has to be some inputs and insights and exercises in practice in order to make him better. So then when we think about our students or we think about ourselves, when I started working on this, I was thinking about what feedback do I get as a clinician, right? So I'm a practicing emergency medicine physician. Here's my feedback. Once a year, I meet with my boss and he goes through my metrics. And my metrics consist of RVUs per hour, patients per hour, my resident evaluations, and they get to determine if they think I'm like a good clinician because they ask the residents that, APPs, maybe nursing, some students. I might get something that says you missed one window to a STEMI or something. But essentially, my clinical feedback is minimal. There's very little that's saying to me, hey, Sally, you didn't recognize this change in practice, or hey, Sally, you're not treating this one appropriately, or too many pain meds, too few pain meds. There's just very little in terms of that, in terms of our clinical practice. And when we think about our students and our residents, it's equally as anemic. Like there just is not a lot of information at the institutions where I work with students. The students basically get, for their 8 weeks on surgery or their 8 weeks on medicine, they probably get a handful of evaluations or assessments from their faculty and residents. And so we're not giving them robust information. Maybe somebody watched their history and physical once because we have to mark it off for the LCME, but essentially we're not getting good data on our students. And so it's really hard for them to improve. And so for this student, you can see if we're just kind of checking off the things that we have seen, we have some view of him. But if you actually go into reality, he doesn't know how to use his stethoscope. And so I like to think of this as the image of what we're actually doing. Our goal is to have a robust picture of what our students and our residents and ourselves can do, and that we hope that we can do this through precision education by getting more data. So let's talk about a definition. So the definition that Dr. Desai and team are currently using is that it is a system in medicine that uses data and technology to transform lifelong learning by improving personalization, efficiency, and agency at the individual, the program, and the organizational level. So key pieces here, data, technology. It doesn't always have to be technology, but data and technology, that it's personalized, efficient, and that the learner, that the person has agency to do it. And ultimately, we hope that this will help patient care. And so that's kind of the definition. The model is as follows. If you look at this model, you're like, oh, it's got these 4 things. You'll actually recognize this model in a number of other models that we use commonly. So the QI model is a plan, do, check, act. You can see that in here. The master adaptive learner is a plan, learn, assessed, adjust. So again, you're seeing a similar thing. And self-directed learning and self-regulated learning is in here as well, which is to say it's probably got pretty good educational background or theoretical background of how it's going to work. So I'm just going to run through each of these steps, and then I'm going to do some exemplars of this. All right, so the first step is really the data. The data should be coming from patient care, the electronic health record, patient exposure, population, quality measures, educational activities, practice patterns. But when you think about it, the data can come from all different sources, and there should be as much data as possible so that we're robustly filling in that grid of our learner or ourselves to make sure that we understand what their performance looks like. The next step in this is that from the data, sorry, this is just random, an old slide from a different talk about all the different kind of data things that we could be using for our data analysis. So from the data, there are going to be there we go. They're going to be insights. So basically, you get all this data in front of us, and using informed self-assessment or advising or coaching or mentoring, we are then going to kind of do an analysis of that data and get insights. And from that, we hope to gain an understanding of the knowledge and skills and gaps by using the information that's there. Now, some of it may actually come from informatics. So an informatics thing may be able to give me a dashboard, but some of it may just be by looking at the information that we have. The next step in this is to look at, oops, the back one, is to look at, you've got your data, you've analyzed the data, you've created insights, and now you're planning and moving to actions and interventions. And so one would hope that this would be, just-in-time educational activities, high quality resources, benchmarking guidelines, or other methods in which to learn what we're doing, that you might actually have like coaching with procedural work. There's a number of things that you could do to try to fill in the gaps which you need as you start to learn. The next step then is the outcomes, and that's going to be an assessment of learning. So you want to get better information about patient performance, patient outcomes, evaluation interventions. And as you can see, this really kind of feeds into itself. And when we've looked at the master adaptive learner specifically, it looks as though it's operating on the micro level. For example, I ordered a medication when I was working in the emergency department, and the pharmacist called me and said, "Hey, Sally, we don't have that, or that's not the right dosing, or you need to weight-based dose it." That was information, gives me insight of, oh, I messed that up. And then hopefully I will learn so that the next time I do it. And so we're probably doing these micro cycles all the time. And then there may be a bigger macro cycle of, if I discover as I'm doing something that, if my EHR was able to show me the number of narcotics that I'm giving for patients with headaches, or the number of CAT scans for headaches, that I would use that kind of at a macro level. But it is to say that this cycle is probably happening in little things and in broader things as well as it should be happening at both the individual level. So it's me as a learner, or me as a practitioner going through the model, but it also happens at the program level. And so if in emergency medicine, we note that we actually noticed recently that our second-year residents were not getting adequate volume of patients because the hospital is so boarded. And so we made adjustments to try to change their room adjustments so that they can see more patients. And that would be precision education on a program level, so that we can use the data to do the same process of changing and interventions to do it. And then it can also be on the system level. I don't know if any of you are emergency medicine folks, but the emergency medicine is a group of the RRC at emergency medicine has decided that EM should go to 4 years instead of 3. There's lots of uproar about that, but they're trying to use data and evidence to demonstrate why it should be a 4-year that every program should be 4 years versus 3. And so that's, again, using data and evidence at a macro level, at a system-wide level, to decide what changes need to happen. So that's the model that we're dealing with. Okay. And it goes through kind of learner, program, UME to GME. The sense is that this is going on all the time, and it needs to continue as we go through. Okay, how? I'm going to run you through some precision education examples, and then I'll take questions at the end. Okay, so the first one is really kind of an input one. And I don't know if any of you know him. There's the internal medicine program director is Eric Warm at Cincinnati. And I asked him for some slides about a couple of things that I really wanted to talk about in terms of the inputs that he's allowed to provide his residents. And he sent me his slide set, which is called Assessment: A Love Story, which he's truly like the assessment guru nationwide. And so if you ever have a chance to talk to him or invite him, please do that. And I'm just going to go through a couple of things that they have done. The first thing is that when the milestones came out, they looked at the internal medicine milestones and said, these are not really measurable things. We need to much more dig down into the performance and the behaviors that we're trying to assess so that we can provide better information. And so what they did was they basically looked at every rotation, and then looked at the level of the resident as an intern versus a senior. And they basically wrote out observable practice activities for every rotation at every level. And they ended up with hundreds of these. But you can see that they're much more meaningful, right? If you're on a general medicine service, did you give it insulin and did you manage the glucose? If you're on a cardiology service, did you treat the STEMI appropriately? And so they really tried to customize each of the OPAs to the level and the resident so that they could get good information from the attendings, from peers, from nurses, from pharmacists, from students and patients. And so really tried to make it kind of a multi-source assessment. The end result of this was that they end up with, as an intern, you have 1,500 minimum, like about a mean of about 1,500 assessments throughout your intern year. And by the time you graduate, they're up to about 3,500. When we were trying to do some analysis of this, he's got over 1 million data points for his residents, which is to say, if you think about our grid with this, the student with the stethoscope on his head, you would know that because you've got the information coming in. And so they are very intentional about collecting as much data as they can, as pointed as it can be, and directed at the behaviors that you would hope to see, the performances that you would hope to see. What they discovered was in this process is they have this resident who's doing really good, and like growing appropriately, and all of a sudden they drop. You can see it in a bunch of these graphs. All of a sudden they drop, and they're like, "Wow, what happened to Jane? She just seemed to like go along, and then she did terrible on this rotation." And when they actually started uncovering the layers of the onion, what they found was there are idiosyncrasies for different rotations. So if you're early in the year, you're not going to do as well. If you're on a really tough rotation, such as cardiology or the ICU, you're not going to do as well. If you've got a hawk as a grader, you're not going to do as well. And so what they actually did is they went through and they created an algorithm which creates an expected code. And so it accounts for all of those things. So that resident who's a great resident who's all of a sudden drops will recognize that they didn't actually drop. They just came across these incidental things that made their work harder so that they are assessed more vigorously. And so they actually have what's called an expected score, and the residents get their expected score so that they know that it is taking into account all of these things for their residency program. And you can see how this is really kind of personalizing the information and the data that they're getting. And it's giving them just a more robust and more trustworthy information so that they can act on it. Another thing that they did was they, often assessments are done to us. And what they wanted it to be that the residents really kind of owned it. And so they have this process every year. It's called defense of the measures. And essentially, as the residents go into their outpatient block, the residents look at the measures from the previous year, and they basically decide which measures they as a group want to be judged on, want to be assessed on. And so this part of their assessment is really aimed at patient level assessments, and that the assessments you need to have some contribution or attribution, like you need to have some part of that. And then, so basically the residents every year, they vote and they do a defense of the measures and they decide which measures they want to be assessed on. And then because everybody's patient panel is different, they then set criterion. And so if I get actually a patient panel where I have really low screenings for foot exams, then my goal is to actually raise it by a 2%, as you can see. Whereas if I come in with a really good panel, then I may not have to worry about it. But they really kind of customize it to the panel that they're getting so that the residents get good information from that. In the end, all of this ends up on a dashboard so that there can be coaching and improvement and things that they can see. Okay, I started with this example because this is a low-tech example. This part doesn't look so low-tech, but in fact, what sits behind this is Eric Worm pulling stuff from Epic on his own and pulling stuff from MedHub and with an Excel spreadsheet creating some of these dashboards. They've just moved to customizing it. And so while the rest of the examples are all like high tech, do you have the technology and informatics to do it? It is to say that you can build an incredibly robust assessment system with millions of data points just using Excel and MedHub if you need to. Okay, that's example number one. Next example is really going to kind of get to the examples are going to get to learn and assess and actions and intervention. So the question is, the problem is here is how do we promote patient level learning? There's a couple of projects that are using nudges and notes assessments. So the first one is a nudge project that is coming out of NYU. And so basically what happens is at night, at the end of the day, the AI goes into the EHR and basically says this student or this resident has seen these patients and they can tell it from their admission notes, and then pushes them information that they can read about that. And so this might be an example of one where the patient was admitted with cirrhosis and alcoholic hepatitis, and it pushes to them, hey, you might want to consider reading some of these things. And or you might want to do some questions on it. And so basically is saying, this is what you're seeing, and pushes them to how they might learn. And this is a nudge project coming out of NYU. Another one that's coming out of a collaboration between Cincinnati and NYU is clinical reasoning. And so NYU had created a platform called NoteSense, which then got a Stemler grant to kind of expand it, both in terms of the number of categories that they're assessing, and then also to expand it to an EHR platform. And so NoteSense is that each of the residents' clinical notes, their admission notes for internal medicine are scored in terms of several domains of clinical reasoning. And then that score goes to their dashboard. And so they can look and say, you know, I was admitted, sorry, it's using I was admitted, you know, when I was admitting patients, this is what I was seeing. And so, you know, if I admitted 5 or 6 patients, I can actually get a NoteSense score for each of the patients, for all of the patients together. And then they also are collecting this information over time. And so the residents, when they go to their dashboard, they can see their overall score, but then they can also say, which patients did I see and how were each of those scored? And so this is a hands-off, technology-based way to provide feedback on clinical reasoning. And you can see like this on the right-hand graph, the note index within SHIFT, that they're actually like decreasing their clinical reasoning as the time goes on. There's also some differences due to the difference of time. And then you can also see that these two programs here that have slightly different percent of high quality notes. Now, is that a system issue, or is that an individual issue? We don't know. We actually have some ideas. One of the programs, the hospital is completely full, and so the person who's coming down to write orders orders notes may actually be a senior resident, and then it gets picked up by somebody else. Okay, so that's NoteSense. This one, if you look at this one, it is playing automatically as I talk through it. And so what this is Dr. Turner at Cincinnati has created an AI patient simulator, essentially. And so what she has done is she has programmed for second years in preparation for their clinical skills exam, a series of cases with minimal specific information. And so what happens is the person says, what level are you? As you can see, it's popped in and says, I'm a second year resident or second year student. And then you start asking the AI, which is your patient, questions. Do you have high blood pressure? What are you here for? Those sorts of things. And then you can move to the physical exam, and it will give you the physical exam. Along the way, you can ask for a blood pressure, you can ask for whatever else you want, you can pop back and forth. You can also then ask for diagnostic studies. You can see here they're asking for, you know, I want to do an echo for this patient in chest pain or whatever. And then you can ask for interventions to treat it in a certain way. And then if you run into difficulty, you can ask the supervisor for information. And then at the very end, it actually gives you a score for what you did. And so the case that I have been, you can see there's the supervisor, the case that I've been scoring, or not scoring, but that I've been looking at is a viral myocarditis case. And so it actually at the end says, here's the questions that you asked, here's the questions you didn't ask, here's the differential you provided, here's the differential you didn't provide. And it actually provides them specific feedback about how they could get better. And so this is Two Sigma doing cases. And it's all AI based. And so every case that comes forward is a different case in terms of what they're doing. And so you can see there, this is the leading diagnosis presents a differential. This is their feedback. And then it goes down to, you can see you did your old carts or whatever you did. All right. That's just another example of providing like just-in-time learning and feedback for this. This is some work that's coming out of one of the AMA grants, GEL, with Reimagining Residency. And the question is, how do I know which activities improve clinical skills and well-being? And so they actually put trackers, or they asked their, I guess put trackers is a little bit wrong to say. They invited their interns and residents to wear location trackers. And so then what they did with this project is they actually tracked the amount of time that physicians spent in the room. And you can see that there is a great variability from residents way up at the top spending more time and residents at the bottom spending less time, which would translate to quite a bit of time over the entire year. They're also able to look at where they were spending the other time they were spending their time. So in general wards, you can see that the majority of the day they're actually spending in the workroom, and during rounds, they may be in the workroom. They may actually go during rounds to the patient room, whereas on specialty services, you may be doing something different. And so this level of precision education is much more at the program level, right? So you can look as a program director and say, or as a if I'm in charge of cardiology and I'm like, I really want them in the room listening to those hearts, or, yeah, I'm on peds and I want them to be in the room talking to the patients and family. And so with this kind of information, you can actually use the data to do program level changes. And so this is coming out of a group called GEL. They're then mapping this to well-being and mapping it to clinical skills. I don't have those results here. But you can see residents are spending different amounts of time in different places, and you can get it to the individual level, although they are not reporting it at the individual level to the residents, they're doing it just at the program level. Okay, so how can I assess individuals' clinical competency in a team-based model? And so this work is coming out of an AMA grant from Cincinnati, Stanford, and NYU, but mostly Cincinnati and NYU. And so here, what they've done is there's the concept that they've coined, which is tracers, which is trainee attributable and automatable care evaluations in real time. And the goal is that we should be able to pull things from the EHR that will provide direct feedback back to our residents, and it should be at the patient level. And so this team, we spent a long time trying to decide what was the measurement we're going to do. And the decision was to use long-acting insulin, so that one should have a basal rate of insulin for admitted diabetic patients. And then, so that was so the inciting event is admission to the general medicine ward. The clinical part is that we had to say, are they a diabetic? And then was insulin given? Then the EHR pulls that out. Then we attribute it to the trainee, but we had to figure out which trainee was getting it because there's lots of orders from other people. And then it provides monitoring and feedback. And so this is the tracer project, really trying to get deeply into the EHR to provide feedback to the residents so that we know how that they're doing. And so this is just early stuff. And so basically what we're seeing, if it's a little bit complicated, you want to be giving a long-acting insulin. And so the long-acting insulin is the top, where's my long-acting insulin? There is the top line. And so the top two boxes. And so ideally every patient that comes in should get long-acting insulin. What they're showing with this is they're actually starting to see kind of these phenotypes of residents who almost never give long-acting insulin, whereas there are others who are mixed, who may give it on some patients, but not other patients. But this allows us at a program level to say, hey, what's the problem? And in fact, it's based on 3 different clinical sites, and they're seeing very different practices in them. While the whole group agrees that a long-acting insulin is important, each of the sites is doing it a little bit differently. And then this information will actually go into into all the residents' dashboards. And so they'll be able to use this information to make sure that they are doing the care that is deemed to be appropriate for their patients. Okay, so problem number 6, or case number 6, it's how do I provide highly specific procedural feedback? That see one, do one, teach one probably doesn't work. You know, when we saw our golf swing, it probably doesn't work to do that. And so this is some simulation, or sorry, these are mostly simulation-based things. They've been trying to do it with the Da Vinci, but I think it has not been as effective. But essentially what you've got here is there are haptics that are basically doing the speed and the pressure of the hands as they're doing the surgery. And this is obviously a simulation model. And what you can see is these are the differences based on who people are. So right hand, left hand, fellow versus attending. And so if you really look at this kind of bottom right hand, you can see that that right hand's hardly moving at all. And how fast or how far or how slow. And the left hand is doing differently, but you can see very different patterns in the way that their hands are moving. And so the goal with this information is to provide this back to the surgeon first to decide what's kind of gold standard, what does it look like, and then to provide it back to the surgeons. And so this is I think it's an American Board of Surgery meeting. It's some sort of a surgery meeting where they're getting a whole bunch of people to go through and enter into their study. It is to say that eventually we should be able to use haptics to help us get better, so that we know, in surgery, which is particularly different in terms of, respect for tissue, that we can use that as well. So our last case or example is how do I provide learning to integrate into my clinical work? And so this is AI-enabled patient relevant learning. And it is the sense of, for most of us who are practicing, I feel badly because I'm not learning enough. Like I feel like I ought to be reading more, listening to more podcasts, and I find some time, but I just never feel like in my field that I can keep completely up to date. And so this one is the AI was in the EHR again, and basically looked at the patients who are coming to outpatient practice. And it basically said, here's the things that are coming in, and here are some things that you may want to look at. And so it basically kind of fed clinicians the things that might help their practice based on the patients that were coming. And what the platform found is that that physicians were spending just about 10 minutes a week engaging in this, but they recalled some of the things that they saw, and mostly because it was, just-in-time learning. It was related to the things that they were going to see. And they said or reported that it informed their clinical decisions. So it helped them become better as physicians. And I would love to have that to say in the ER, but regardless, at the end of the day, it would be really helpful to say, here's the practices that changed, and these are the kinds of patients you saw, and this might be something for you to read, because it would certainly make it more easy to do that. All right, we have been through the precision education model a number of times, seeing different things, and you can see how it all kind of integrates. It's all basis on kind of having data and doing something with that data, and then getting some sort of a feedback to make sure that the data that you're getting or the stuff that you're doing is effective. And so just some final thoughts for this. It's early, I think, is the first thing. Like, we're just learning these. I think that when you look, like, you're like, sure, it'd be easy to pull out the insulin. Like, we thought that would be like done in a year. I cannot tell you how hard it was to try to get the insulin orders out. And similarly with the NoteSense one, clinical reasoning, it just turned out that they're all that, an Epic system is not an Epic system. An Epic system is a University of Cincinnati Epic system or an NYU Epic system. And so these are difficult, and there are lots of lessons to be learned along the way to get it more effectively. I think that's why I really start with Eric Worm's system of MedHub and an Excel spreadsheet, because we all can get more data, and it's a question of doing it. And so where is the data? How do we get it? How do we bring it in so it's into our view? and then using AI or other things, technology to make it easier visualized or analyzed. But the other thing that with this and the brain on the brain on the left is there's a lot of information coming back that people don't like feedback. And they're resistant to it. There are some that embrace entirely. We know that self-assessment is not very effective. Informed self-assessment is better. We a lot of fixed mindset. I don't want to think about the things I don't do well, and not growth mindset of grabbing the things you don't well. And I think that this brain and our behaviors is still a black box, and that we really need to spend some time thinking about how do we provide information back so that people will take those inputs and analyze them and get insights so that they can do something about it. And I think that's, the work is in the data and the technology and all those things. But I think there's also a lot of work that needs to be done in terms of, is it coaching? Is it really coaching? Is it feedback? Is it informed self-assessment? Like, how do we get people to embrace taking the data and moving to improve in that way? All right. That's what I got. Oh, one more thing. Sorry. There are Rena probably knows this and she's probably shared this. There is a big grant application that is open. It is due on the 21st. So this does not give you a huge amount of time to think about it. But basically there's a $1.1 million grant that will go in for LOIs for precision education with AMA. And the website for that is there. All right.